Okay, Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome you all in our second wave of the Heart Failure Group of the Emirates Cardiac Society virtual webinar meetings. I'm really excited and happy to be here. My name is Dr. Mohammed Al Harari. I'm a consultant cardiologist at the Tawam Hospital in LA. We have really excellent two speakers from two different countries in the region. Dr. Matluba Zijali from Oman and Dr. Salah Berry from Qatar. The theme of our meeting today is on the HFpEF. So we'll be kicking off shortly with Dr. Matluba Zijali on the challenges in diagnosis of heart failure, and followed by Dr. Salah Berry in the unmet needs in the HFpEF management. And I will finish off with a symposium on focusing on the use of ARNI in the HFpEF. The way we are planning it, that we'll have the three talks, following which we'll go through the discussion. Throughout the talks, you can write your questions. Unfortunately, with this system, you cannot voice your question. You can just write them and we pass to us, and we will answer them at the end. So, but you can feel free to start question from the beginning. So our first great speaker is Dr. Matluba Zijali. She's a consultant public health, cardiovascular disease and heart failure specialist. She's a fellow of the European Heart Failure Association and a fellow of the European Society of Cardiology. She's the managing director of Heart Vascular Center and board member of Oman Heart Association. It's really a great pleasure to have her with us tonight, and she will kick off talking about challenges in the diagnosis of HFpEF. The floor is yours, Dr. Matluba.
Thank you very much, Dr. Hariri. Dear colleagues, good evening. So as Dr. Hariri mentioned, that we are going to talk about very challenging topic, which is HFpEF. As we all know, there is very limited data on HFpEF in the literature. So I'll be talking about the challenges in the diagnosis of HFpEF. So you just bear with me, and then let's see what is the challenges for the HFpEF. First, I would like to start with the case presentation. So she is a lady of 72 years old who presented with 4 weeks history of progressive shortness of breath, fatigue, and mild peripheral edema. She was diagnosed 10 years ago as a hypertension. Clinically, she's obese with BMI of 32. Her blood pressure clinically was a bit high, 190/110, and she was tachycardic as well, but in sinus tachy, I mean. So on examination or clinically, she had bipedal edema, and her JVP was raised, and on auscultation she had S3 gallop and basal crepitations. So clinically she was in LVH, and her blood investigations all revealed normal, including hemoglobin and blood glucose. However, her renal function was a bit deteriorated with eGFR of 48, but her potassium level was within normal range. She had an ECG which showed left atrial enlargement and LVH with a strain pattern. So here we all suspect that by the signs and symptoms that this patient is in heart failure. So the next question comes, how would you diagnose the type of heart failure? So obviously she had an echocardiography which showed normal systolic function with ejection fraction of 65%. And she also had mild left ventricular hypertrophy, but there were no valvular pathology. And there was a comment made on the presence of diastolic dysfunction with an enlargement of left atrium and increase in the E prime ratio. So this actually demonstrates that the chest X-ray, the patient was in frank pulmonary edema, and this is the left ventricle. If you see it by the eyeball, it looks like it's not dilated or looks normal LV. So HFpEF, it's defined as a heart failure by symptoms with a normal or near normal LV ejection fraction of more than 50%. and the cut point, which actually does not exclude the mid-range or mild systolic dysfunction. So the term preserved ejection fraction is preferred because ejection fraction, it is what is usually or commonly we measure. And HFpEF, it's often equated with the diastolic heart failure. So this is actually adopted from the European Society of Cardiology. So it's about the definition of HFrEF versus HFpEF. So the diagnosis for HFrEF, there should be 3 conditions satisfied. First, patient should present with symptoms of typical heart failure and signs of typical heart failure and reduced LV ejection fraction. Whereas for the HFpEF, it requires 4 conditions: symptoms of typical heart failure, signs of typical heart failure, and also the LV ejection fraction is normal or mildly reduced, but it's not dilated. And there is also relevant structural heart disease, for example, left ventricle hypertrophy or left atrium enlargement or diastolic dysfunction. And again, the European guideline, they divided or they classified heart failure into 3 types. We have HFrEF for heart failure with reduced ejection fraction, HFmER for heart failure with mid-range ejection fraction, and HFpEF is heart failure with preserved ejection fraction. For HFrEF, to diagnose HFrEF, as I mentioned, you need 3 major criteria: sign and symptoms of heart failure and LV ejection fraction cut point less than 40%. Whereas for HFmER for heart failure with mid-range ejection fraction, again, you need signs of heart failure, symptoms of heart failure, LV ejection fraction 40 to 49%, that's the cut point. And there is also the 3rd criteria, which is increase in the natriuretic peptide, and also there should be 1 additional criteria available, for example, relevant structural heart disease like left ventricle hypertrophy or left atrial enlargement or diastolic dysfunction. For HFpEF is more or less the same of HFmER, but the LV ejection fraction is more than 50%. So what's the difference between HFrEF and HFpEF? So HFrEF, actually, it's a disease or a condition of volume overload. So it's always characterized by eccentric hypertrophy. So it's result into the thinning of the left ventricle, and it decreases the systolic function and enlargement of the left atrium volume. Left ventricular volume, sorry. So whereas for the HFpEF, it's a condition of pressure overload, and it is characterized by concentric hypertrophy growth, and it results into the normal size left ventricle cavity, but it is thickened wall and preserves systolic function. So the universal definition for the heart failure provides a straightforward approach for the clinician to determine if the person presentation is consistent with heart failure. So in the universal definition, as I mentioned, you need symptoms or signs of heart failure, which is caused by structural or functional abnormalities. And it is incorporated by at least of the following: increase in the biomarkers, which is NT-proBNP or BNP. And also there is an objective evidence of cardiogenic pulmonary congestion or systemic congestion. So this is very important for the universal definition of the heart failure. And also studies has been demonstrated that there is a correlation between some comorbidities or risk factors and HFpEF. For example, HFpEF, it's more common in patients with advanced age, patients with atrial hypertension, and it is more in female gender compared to men. And also it is more common among patients with kidney disease, metabolic syndrome, obesity, pulmonary disease, and sleep apnea. So these are the most important comorbidities or risk factors which can be associated with HFpEF. So for the diagnosis of HFpEF, as we mentioned, that symptoms and clinical signs of heart failure, echocardiography, and increase in the biomarkers, for example, NT-proBNP, this is all considered to be a universal definition for the diagnosis of heart failure. But there should be also an absence of major comorbidities, condition which that mimics heart failure presentation, for example, chronic kidney disease, COPD, or anemia. So this is a flow chart actually demonstrates the approach how to diagnose heart failure with preserved ejection fraction. For example, patient presents to you in your clinic with exertional shortness of breath. So you need to take a history of the patient, perform your physical examination, and then you need to measure the natriuretic peptide. and also look for the other causes which can cause exertional dyspnea. And then you have to assess the risk factors, profiling for the patient, profiling, for example, advanced age, hypertension, or increase in the BMI or obesity. So as we know, if the NT-proBNP or the biomarkers is more than the cut point that's mentioned by the guideline, and you excluded the other diseases, then here you need to perform the echocardiography at resting. So for the echocardiography, you need to look at the certain things. You look at the pulmonary pressure, there will be increase in the pulmonary pressure, left atrial enlargement, and there is also increase in E and E prime ratio and increase of the wall thickness. So, or LV mass index should be more than 115 gram per meter square. So, if, for example, you do all these approaches to diagnose the heart failure, we need also, as per the guideline, to consider exercise study in order to confirm the diagnosis, either by exercise right heart catheterization or stress echocardiography. And we all aware that exercise right heart catheterization, it's not available in all practice, and it is also not feasible in the clinical practice. Whereas the stress echocardiography, it is non-invasive measures, but again, it might be not practical or not present in the all clinical practice or clinical practice setting, I mean. So the key diagnostic criteria for HFpEF, preserved ejection fraction should be the cut point more than 50%. And there is also a structural changes in the echocardiography, like LA volume index should be more than 34, and left ventricular mass index also should be increased with different cut points between men and women, or male and female. And then you also, in the echocardiography, we look at the functional alteration, the E and E prime ratio more than 13. And then we go for the NT-proBNP and BNP biomarkers. If it is more than the cut point, then these are the most important criteria we need to look at. And lately, there was a lot of studies. Actually, they tried to develop some scoring system in order to diagnose the heart failure. So we have, I'll mention here or discuss two scoring systems, which can be used at the clinical setting in order to evaluate the patient who are suspected with HFpEF. So we have H2F PEF, and then we have HFA PEF algorithm, which can be used as a scoring system in order to determine the HFpEF and underlying etiology in patients who present with shortness of breath. For H2 FPEF, we have H2 is actually it's for the heavy patient, or it is stand for obese patient with BMI more than 30. So this will take around 2 scores. And then we have patients with 2 antihypertensive medication. That's when patient is with high blood pressure. So here the score or the point will be 1. F is stand for atrial fibrillation with 0.3, and P for pulmonary hypertension, and you have 1 point for it, and then E for elderly patients more than 60 years old with 0.1, and then we have F for the filling pressure with E prime ratio more than 9 on Doppler echocardiography. If, for example, these points is more than 6, then it is considered to be that patient having heart failure with preserved ejection fraction. So H2 PEF score also derived and validated using the gold standard, of course, which is a stress cardiac catheterization, right heart catheterization, in order to confirm the diagnosis of HFpEF. So there is another algorithm called HFA PEF. So this is actually involved some potential hemodynamic assessment, and it includes 4 steps. So the first steps, it's pre-test assessment. So here it looks at the symptoms and signs of heart failure as per the universal definition of heart failure, and also it looks at the comorbidities and risk factors which is contribute in causing or correlated with the HFpEF, and also standard echocardiography. And step 2 or E, it is echo and natriuretic peptide scoring. So here you have to do the comprehensive echocardiography and the biomarkers natriuretic peptide in order to reach to the diagnosis. And then in the echo or comprehensive echocardiography, you have to look at certain things, for example, functional and the morphological alteration in the echocardiography. Step 3 or F1, it is functional testing in a case of uncertainty. For example, if we are still in confusion or not certain that this patient has HFpEF, then here you have to do diastolic stress test or exercise echocardiography or invasive hemodynamic measures. So again, this is quite difficult, and it is not might be feasible in all settings. For step 4, F2, the final etiology, then here you need to do special imaging, for example, cardiac MRI, CT, PET scan, or biopsies or genetic testing. So this actually is important in order to look for the mimics, which is contribute in causing HFpEF or exertional dyspnea. So for this score, if, for example, patient had more than 5 points, then here you can consider in your mind that patient might have HFpEF. So for this scoring system, actually, there is certain limitations. For example, natriuretic peptide level are generally lower in individual with HFpEF compared to those with HFrEF. And this is making the rule of natriuretic peptide very challenging, especially in individual with HFpEF and obesity. So what happens with the obese patients? It's significantly, there is a lower natriuretic peptide concentration. And this also results into the natriuretic peptide value below diagnostic threshold for heart failure. And it is the presence of elevated, so invasively it's measured cardiac filling pressure. So this might make the role of the natriuretic peptide not very much considered in diagnosing HFpEF. So, however, the other scoring system, H2 FPEF, it does not include the natriuretic peptide in the scoring system. So this may also be problematic because an increase in the natriuretic peptide level, it's one of the components for the universal definition for heart failure. So ultimately, a high suspicion of HFpEF and low threshold for further evaluation, it is warranted in individual who presents with shortness of breath and obesity before attributing to all symptoms to obesity. So there is another potential limitation to HFpEF algorithm. It's particularly step F1, which is, I think, step 3. So the diastolic stress testing that they mentioned in that step, it is invasive, as I mentioned. And also it is not feasible in all clinical settings or clinical practice. So this is considered to be one of the challenging of this kind of scoring system. But the diagnostic approach for HFpEF, for example, if you are having patient who presents with shortness of breath or edema, you need to assess for non-cardiac sources. And then also you need to apply the universal definition of heart failure, and then you need to assess for the heart failure mimics, and then assess the likelihood based on the scoring system or algorithm that we mentioned, particularly H2 FPEF score, and then you ultimately reach to the diagnosis as the HFpEF. So as I mentioned that it is considered to be one of the diagnostic approach, which is focusing on the evaluating the differential diagnosis of shortness of breath. If any mimics that is bear in your mind, either it is cardiac or non-cardiac, so you need to rule it out. So there is another point we need to look at for diagnosing in HFpEF. It's the sex-specific differences. So it's compared with men, as we mentioned, as per the studies, that women with HFpEF tended to have more significant symptoms of shortness of breath and more likely to have worse health status. So physical examination is generally similar between women and men with HFpEF. However, the diagnostic testing may reveal important sex-based differences. So for the non-cardiac disease mimic for HFpEF, some individual who presents with symptoms of shortness of breath and edema may not have heart failure. So there are non-cardiovascular entities that which may mimic the heart failure, including, for example, kidney disease, liver disease, severe obesity, peripheral edema, pulmonary congestion or any pulmonary hypertension or lung diseases. So this is all considered to be non-cardiac mimic we need to consider or look at. And again, based on the clinical presentation and evaluation of the individual who present with symptoms and signs of heart failure, for example, particularly shortness of breath and edema, here you need to include, for example, urine analysis to assess for proteinuria, to exclude kidney diseases, and also we need to consider abdominal ultrasound to assess for the liver cirrhosis, and also pulmonary evaluation with imaging or spirometry to rule out any pulmonary disease. So this slides actually, it's demonstrate two different individuals who presents with shortness of breath on exertion. For example, in individual A, so this is a woman, 68 years old. She had stage 4 chronic kidney disease and atrial fibrillation. And she also has a history of hypertension. She's on 3 medications. Her BMI is 31. Whereas individual B, this is 68 years old man with the stage 4 chronic kidney disease and atrial fibrillation. And also he had carpal tunnel syndrome and lumbar spine stenosis with BMI 24. So the ejection fraction with increased left LV wall thickness in the echocardiogram was seen in this both individual, and E&E prime ratio was quite high, and estimated pulmonary arterial systolic pressure was almost 40 millimeter mercury. So in individual 1, the scoring system H2 HFpEF was a score 9, and then for individual B, it was 6. So it's the same actually symptoms of heart failure with the suggestive of HFpEF, but both but the scoring, what I meant to say, the algorithm is quite different between both patients. Like if you see in the individual 1, the point was 9, and the individual B, it was 6. So this will tell us that the second individual, the man who is 68 years old, actually he has likely HFpEF mimic, which is attributed to the specific disease entity, and also it requires a specific disease-directed therapy. So this is the stepwise approach to assess individual who presents with shortness of breath and edema. First, patients with shortness of breath and edema, ejection fraction more than 50, you need to apply the universal definition of heart failure. Then you have to look for the non-cardiac mimic. For example, if non-cardiac mimic is a primary non-cardiovascular entity causing the symptoms, if the answer will be yes, then the congestion primarily could be from other diseases, for example, kidney disease, liver cirrhosis, or chronic venous insufficiency. If there is no non-cardiac mimics, then here we have to look for the HFpEF mimics, which might be one of the cause of shortness of breath on effort. So heart failure might be attributed to different diseases, for example, infiltrative cardiomyopathy or hypertrophic cardiomyopathy, valvular heart disease, or pericardial disease. So if, for example, the HFpEF mimics is not present and the HFpEF is identified, we need relevant comorbidities to look at, which is contributing into the presentation for the patient. So here we need to look for the other comorbidities, for example, hypertension, diabetes, atrial fibrillation, and sleep apnea, etc., because this is very important also to look at in order to manage the comorbidities. So emphasizing the contribution of non-cardiovascular entities as well as HFpEF mimics to the presentation of congestion. This is actually reinforced the importance of establishing diagnosis in order also to optimize the disease-directed therapies. And also when the mimics are excluded and the diagnosis of HFpEF is made, so there is an extending the diagnostic label of HFpEF should be identify the associated comorbidities as we mentioned in our previous diagram. So that's emphasized the need to address these contributing comorbidities to improve symptoms and the outcomes. So for the challenges of diagnosing HFpEF, first challenge in the diagnosis of HFpEF, what we said that the ejection fraction threshold constitutes HFpEF, and it is based on the universal definition of heart failure. HFpEF is defined as a clinical diagnosis of heart failure with the ejection fraction more than 50, and those individuals with ejection fraction between 40 to 50% are noted to have mildly reduced ejection fraction or mid-range ejection fraction or HFmEF. So individual with HFmEF, individual with HFmEF, it is also, sorry about this. So individual with HFmEF, it is comprised a diverse group, including those with important symptoms. So the separation of HFmEF and HFpEF, it is useful because it provides distinct category for those individuals with stable preserved ejection fraction, and because, as we mentioned, ejection fraction measurement, it may vary depending on the imaging modalities and also interpretation methods. So another challenging in the diagnosis of HFpEF is using the correct terminology, and also HFpEF, it is not synonymous for the diastolic dysfunction. So the presence of diastolic dysfunction on echocardiography, it is neither specific nor sufficient to make the diagnosis of HFpEF. And also ICD-10 codes, it is actually for diastolic failure, it is not an accurate or appropriate term for constellation for the diagnosis. So there is another major diagnostic challenge in HFpEF is that there is no single test that can be definitely establish the diagnosis. So it is paramount to consider potential mimics, both non-cardiac and cardiac, that may present with the sign of congestion and symptoms of shortness of breath or exercise intolerance or congestion with preserved ejection fraction. So these mimics have also distinct pathophysiological mechanisms and also failure to consider any additional diagnosis, which may result in the missed opportunity to institute effective disease-directed therapy. So, dear colleagues, I will be concluding my talk emphasizing that HFpEF, it is a polymorphic condition, and also for the scoring system or algorithm, it is both that we mentioned I mentioned in this presentation, it can aid the clinician in diagnosing HFpEF, but again, there are a lot of limitations and there are discrepancies between the both algorithms' scoring system. So the diagnosis appear to be best made by clinical sign and symptoms, which is supported by echocardiography, Doppler, and nitrotic peptide. Thank you very much.
Thank you, Dr. Matlouba. Really great. I mean, this is a very challenging topic for a diagnosis, which is not always straightforward. Very, very nice, very comprehensive. We'll show them to raise those questions later on. So moving on to our next talk, it's really, really my pleasure to introduce my great colleague, Dr. Salah Al-Badri. He's a consultant at the Department of Cardiovascular Medicine of Heart Hospital, the Hamad Medical City in Qatar. He holds a dual appointment in non-invasive department and heart failure team, and he's the Associate Program Director of the Cardiology Consolidation Fellowship Program. I'm sure we will learn a lot from his talk, moving on from the challenging diagnosis to the unmet needs in the heart failure with preserved ejection fraction management. So, dear Salah, the floor is yours.
Thank you, Dr. Mohammed. I'm really delighted to be with you today. These are my objectives. Actually, I'm in the middle, so maybe you'll have overlap with, I will have overlap with Dr. Matlouba and Dr. Mohammed, because the unmet needs extended to the diagnosis. You know, we have a lot of HFpEF patients treated by non-cardiologists, and some like hypoventilation syndrome or labeled, you know, COPD disease as and the patient has something else like HFpEF, and we have this dilemma in diagnosis. I'll be talking about traditional therapy and what do we have now in our hands in treating this challenging syndrome. So in daily life, we have these two patients presented to our department. Patient with similar signs and symptoms of heart failure. The one in the left with dilated left ventricle, reduced ejection fraction, is completely exposed. We know everything about him. We know how to work up, diagnose. We know his treatment, therapy devices, when to refer to advanced heart failure therapy. The one in the left is more difficult and challenging. HFpEF is the most common type of heart failure nowadays. We have more than 64 million patients. More than 50% of them are HFpEF, and the prevalence is increasing every year. So who are these patients? Epidemiological studies saying the majority are older women with hypertension. If you look to switch heart failure registry, if we compare HFrEF with HFrEF, they are older age women with atrial fibrillation. And if we compare HFpEF to HFrEF, in HFpEF we have again older women with atrial fibrillation. So if you face a old woman with hypertension and atrial fibrillation with dyspnea, you have to suspect heart failure with preserved ejection fraction. What about male gender? This Asian study is saying that if we have a young HFpEF patient, the majority will be obese and men. This is not limited to Asia. Here we have a SHARM trial, iPreserve, and TOPCAT trials saying again the same. Younger patients with HFpEF are obese men. And there is global variation, and we have to recognize different pattern. For example, now here we can get a lean pattern, Asian lean pattern. This patient will appear like healthy, lean, but we should not be misled with this because they will have more visceral fat and high risk of morbidity and mortality of heart failure. And as nicely illustrated by Dr. Matluba, diastolic dysfunction is not synonymous with HFpEF. We could have healthy patient with diastolic dysfunction and comorbid with diastolic dysfunction, moderate to severe. So, and as well as in HFpEF. So this is not, not equivalent. So we have diastolic dysfunction in healthy persons as well as in patient with HFpEF. Just quickly, this is just a test of memory, what already nicely given by Dr. Matluba. If we suspect this is the European Society of Cardiology saying, suspect heart failure, elevated natriuretic peptide, then you do echo, and then you classify according to the ejection fraction. And the universal definition of heart failure, saying heart failure symptoms and signs due to structural or functional cardiac abnormality. And then you add one thing more, elevated natriuretic peptide or objective evidence of cardiogenic pulmonary or systemic congestion. Simply chest X-ray with congestion. It's straightforward, no problems at all. But this is heart failure. But we should not forget that it's HFpEF, that this is the heart failure with the preserved ejection fraction. We should not forget that HFpEF is HF first. And abnormalities which are consistent with the differential diagnosis, LV mass index, LVA volume index. Remember here, if we have atrial fibrillation, then the value will be more than 40, and it's not 34. The E over E prime, more than 9, and then the cutoff pro-BNP, And remember that in ProBNP, we have about 20% of patients with proven HFpEF have low ProBNP, especially obese patients, as you know. The pulmonary artery systolic pressure more than 35. So these are findings which can be consistent with the diagnosis. We suspect the HFpEF patient, clinical suspicion, like old women with hypertension, atrial fibrillation, younger man with obesity. Look to the symptoms and signs, and then ejection fraction above 50, not recovered or improved, because these are different population. We'll talk about them later. Evidence of cardiac structural or functional abnormality with diastolic dysfunction, raised natriuretic peptide. So it is most of the case straightforward. Sometimes we get difficult patient, like patient with exertional dyspnea. You examine him, he has no congestion. So you don't know whether this is a heart failure or normal birth. You do echo is normal. So that's why we have this validated score from Mayo Clinic for this ZEBRA difficult cases, you know. So if you, it's already given, I will not repeat it again by Dr. Matluba, but I will just give you an example of how difficult is this scenario. 65 female, obese, non-hypertensive, she came with exertional dyspnea. She has no other symptoms. You examine her, no pedal edema, no congestion, nothing. She's obese. You did the ProBNP is normal or very low, 45. She has atrial fibrillation and the ejection fraction is 60%. She has no diastolic dysfunction by parameters. So we have only E over E prime 11. The cutoff, 14 for diastolic dysfunction. Now the RVSB is 32 only. So what do you think? HFpEF is established. HFpEF is ruled out. We need to do diastolic stress test, or we need to repeat NT-proBNP. It's a lab error. Just we'll solve it together, just for time sake. H2, 2 points. F, 3 points. So she is heavy, obese, 42, more than 30, so 2. Atrial fibrillation will take them 3 points. That's very important. If you have patient with atrial fibrillation, we'll take the maximum 3 points. RVSP 32, 0. And she's above 60, 1. And E over E prime more than 9, 1. And total 7. If you have more than 6, your diagnosis is done. So she's HFpEF. This is the use of this score. This is a validated score against, as mentioned by Dr. Matluba, by invasive method. So it's a good one. Now that this is the HFA-BEF score, I will not read it because it's already here, and you can check the reference in European heart failure. If you have more than 5 points, then HFpEF. If you have less than that, like 2.4, you need the diastolic stress test. If it's 1, then it's excluded. The stress test, you do the stress test. If the E over E prime more than 15 raised in the stress, or TR velocity more than 3.5, the E over E prime more than 15 will take 2 points, and the TR velocity more than 3.4 will take 3 points. And if it is done, then you have the diagnosis. You have almost 5 points here. Now you go for invasive, either with exercise or without exercise. If you have LVEDB more than or equal 16, then this is a positive test for HFpEF or pulmonary capillary wedge pressure more than 15. And if you have invasive hemodynamic with exercise, pulmonary capillary wedge pressure more than 25 is diagnostic of HFpEF. It is challenging, and we have limitations already given by Dr. Matluba, the natriuretic peptide, which is an HFA-BEF score. The values are below diagnostic threshold for heart failure in obese patient. And H2-BIF score, they didn't put natriuretic peptide, which is a problem because it's one component of the universal definition of heart failure. And we have many patients with intermediate score requiring diastolic stress tests and invasive hemodynamics, which are usually not feasible in routine clinical practice. So make it simple. Signs and symptoms of heart failure, ejection fraction more than 50, elevation natriuretic peptide, and then we have to look for proof of structural heart disease, LVH or left atrial enlargement, and we exclude other non-cardiac causes and exclusion of infiltrative cardiac disease. Not to miss amyloidosis, HOCM, sarcoidosis, constrictive pericarditis, valvular heart disease, coronary artery disease. So these are mimickers, and we have to look for, especially if you have a very high ejection fraction. And when to refer to HFpEF patients, we have this check-in. If you want to, if the primary care clinician refer to cardiovascular specialists, collaboration, high-risk feature, extensive evaluation needed. If you have a cardiorenal syndrome, if you aware of heart failure, HFpEF mimickers, or you need your patient had like increased need for diuretic agents, or if he's very symptomatic. And from cardiovascular specialists to advanced heart failure specialists, inhale in need of diagnosis, challenging diagnosis, non-responsive to diuretics, or hospitalized or frequent flyer, acute on chronic end organ dysfunction, low blood pressure, or evidence of HFpEF mimickers, inhale. The HFpEF is, I believe, is a systemic syndrome, inflammatory disease. It is like systemic lupus, you know. So it is started outside the heart, like the HFrEF, where we have the start from the heart, you know, and then we have the compensatory mechanism. This is completely different. We have comorbidities, obesity, diabetes, for example, hypertension, which induce systemic inflammation that affects lung, myocardium, skeletal muscles, kidneys, and leading to these phenotypes of HFpEF with involvement of pulmonary hypertension, myocardial remodeling, skeletal muscle oxygen extraction problems, and etc. So this is inflammatory disease, and probably this is one of the reasons that HFrEF therapy were not, largely very effective in treating HFpEF. So along with treating HFpEF, we have to treat the comorbidities, atrial fibrillation, rate versus rhythm control. It should be addressed adequately and treated. Hypertension, we have to have our targets less than 130, 80. We use all medication which are helpful in this category. And if we have coronary artery disease, we test and intervene if needed. Diabetes, our hemoglobin A1C target would be like less than 7. SGLT2 should be used as first line. GLP-1 receptor agonist if obesity or high risk for atherosclerotic cardiovascular disease. We need to avoid some anti-diabetic medication which are known to you, like saxagliptin, CKD, RAS inhibitor, and SGLT2 may slow progression of renal disease and should be used. Sleep apnea is very important and should be addressed and should be treated and referred to specialists for proper follow-up and treatment. And the obesity phenotypes, which is the obesity phenotype is one of the most difficult type of phenotype of HFpEF. We need to aim for weight loss, improve hemodynamics and functional status and quality of life. We have reasonable evidence about semaglutide in this field. How to treat HFpEF patient? So for a long time, it was just empiric. The treatment was empiric. We consider alternative diagnosis, symptomatic treatment with diuretics, which are very important, of course, congestion. So it is class 1 and it is valid until now. So symptomatic treatment of diuretics, ischemia treatment, hypertension treatment, other comorbidities, perhaps rate control in atrial fibrillation, and some will advocate maintain sinus rhythm, but largely is empiric treatment. This is not because of lack of trials. For the last 20 years, we're trying to treat HFpEF with the same way of HFrEF. So we have here the sham preserve, PIB, CHF, I-preserve, TUCAT, all results in non-significant reduction in cardiovascular mortality. If you take them all together as meta-analysis, we have a modest 11% reduction in cardiovascular death and heart failure hospitalization. They work, but they were not powered enough to show the benefit. This is the meta-analysis saying that they might be helpful in some way. Spironolactone, it was non-significant outcomes overall, but the story of the two population, we have, when they unblinded the study, they have two population actually, one in Russia, Republic of Georgia, and this group of patients were with very low events. Actually, most of them, they were not heart failure patients. And some of them, they were not taking the aldactone, as demonstrated by the lack of metabolites of aldactones. While the other population was in US, Canada, Argentina, and Brazil. They were with events consistent with heart failure, and it was a positive trial in that group. That's why it is in the guidelines as 2B. We have to be aware that the effect of spironolactone will wane once and will decrease once the GFR is coming down, and at the same time there exists discontinuation when the GFR is coming down because of CVT issues. And this is, very important and we start to listen now to this term, attenuation. It was found in SHARM trial that the effect was okay until around 50%. So attenuation of effect at 50%. So this observation SHARM trial, and it was the same in spironolactone trial. The TUCAT trial was the same attenuation. So these medication were like working well around the mid-range or mild reduced ejection fraction. What about the angiotensin receptor neprilysin inhibitor, ARNI? ARNI were very effective in treating HFrEF. And just in short, we have a small trial done before Paramount. It was like pilot study, was successful. And then we have this larger trial. Studied the primary endpoint was total heart hospitalization and cardiovascular death. It used active comparator, valsartan. The result, as you see, just missed, shy to reach the statistical significance, we can say. And 7 events were would change the statistical significance to positive. Anyhow, it was like 13% non-significant reduction. But at the same trial, it showed improvement in quality of life and from NYHA functional classification. The KCCQ score more than 5% was significant compared to valsartan, as well as the renal composite endpoint 50% more compared to valsartan. What was very interesting in this study that, when we are studying pre-specific subgroups, we are looking for consistency. So it was here heterogeneous results. You see the females good benefit compared to male. And then a patient with ejection fraction median around 57, good benefit compared to higher ejection fraction. And if you take the primary endpoint, was like 22% reduction in primary endpoint if you take for these two. So it was beneficial in patients with ejection fraction below normal, below 60, and higher ejection fraction in women. And recently, just we have this trial just last month, Paraglide. It complement the Paragon, actually. If you remember, Pioneer complement Paradigm trial for chronic HFrEF. It was used for hospitalized patient. This trial is almost same because in Paragon they excluded the decompensated patient. And this trial showed there was like 15% greater reduction with Sacubitril valsartan compared to valsartan. You know, reduction in proBNP is a marker of improvement in heart failure. The same observation was seen here again. The benefit was obvious, 22% greater reduction with Sacubitril valsartan compared to valsartan if the ejection fraction below 60%. They pooled both Paragon and Paraglide in one trial. And in Paragon, there was like a group of around 600 patients were like recently hospitalized in 30 days. You know, these patients got benefit more than others. So the primary pooled was like first with 1,088 patients. The Paragon trial, or we say Paraglide, heart failure like in Paragon, and the whole Paraglide trial. And the secondary pooled analysis was the two trials, the two population. So the first population showed that it was significant reduction of total worsening heart failure events and cardiovascular death. Absolute risk reduction was 7 per 100 patient year. It was very significant. And then even the pooled for all patients, results were also excellent and significant. We come to sodium glucose cotransporter 2 inhibitor, SGLT2 inhibitors. You know, it was the first clear success. It was the light in the end of the tunnel, as we can say. And the first success was in ImberioPreserve trial. It was a very large trial, 5,988 patients with diabetes and without diabetes, with a structural heart disease or heart failure hospitalizations. And it achieved the primary endpoints by 21%, statistically significant with very low p-value. When they studied, this is a subgroup analysis for both ImberioPreserve and ImberioPooled, the ImberioReduced and preserved. So when they studied the subgroup, they had the same attenuation issue, or seems to be similar things here. We have around more than 60 here and 65 in the pooled analysis. So there was a question whether this is a true heterogeneity or simply random subgroup findings. And Deliver trialists, they took this and they put it in primary endpoint on their design, and they put the 60%, below 60%, and more than 60%, just to study whether there is any attenuation and to avoid, a negative trial. So the results were almost consistent with the previous trial of ImberioPreserve. It was the primary endpoint slightly different, cardiovascular death and heart failure worsening, and the reduction of absolute risk, the relative risk reduction was 18%, with very low p-value, as you can see. So it was they achieved their primary endpoints, and this is very important. 3 pre-specified subgroups, And it showed here that if the findings are consistent, uniform, below 60 and more than 60 in this trial. Also, you can see here in the bottom, improved ejection fraction. This is the first time we've studied this. Improved ejection fraction patient who had like ejection fraction below 40 and then improved above 40. This is the first time we have a study about improved ejection fraction. It was like 18% of the total population of the DELIVER trial. And it was consistent. The improved ejection fraction category improved with dapagliflozin compared to placebo. And if you take all these outcomes all together, so they were all to the left, consistent, if the ejection fraction below 60 or more than 60%. So there is no hint of attenuation at all. And we take care of keeping the patient outside the hospital and keeping them, with a good quality of life. Here we have the Kansas City Cardiomyopathy Questionnaire, and the mean baseline to 8 months, and mean change was 2.4, which is a very good, results compared to placebo. The dapagliflozin threshold of like improvement of more than 5 points, 10 points or 15 points were more in favor of dapagliflozin this time, and less worsening by more than 5 in favor of dapagliflozin. Then they pulled DELIVER and DAPA-HF to study the cardiovascular death. As you know, DAPA-HF was a positive trial regarding the two primary component of the cardiovascular death and hospitalization. So cardiovascular death was reduced in DAPA-HF. Some were like disappointed because the DELIVER trial did not show the same, the cardiovascular death. Probably it was not powered enough. The events on HFpEF is 50% of HFrEF usually. Patient with HFpEF would die with cancer and infection, different things, So when they did the pooled analysis, they achieved 14% reduction, a statistically significant finding here. And there is no, interaction. And then Vaduganathan had the meta-analysis here, the bold analysis for both DELIVER and EMBERIOR, just to see whether it's a class effect or EMBA's better than DAPA. So they were all, consistent, and cardiovascular death of first heart hospitalization was overall same, and they got the same benefit with the meta-analysis shown composed relative risk reduction of less than 20. The cardiovascular death was just a touch one here. Heart failure hospitalization was significant in both trial and in the meta-analysis. And here then we come to the point of attenuation. And if you see the ejection fraction more than 60, the meta-analysis saying that what happened in EMBERIOR PRESERVE was maybe a chance error only, or this is not, because they are consistent now. It's a class effect. They are no hint of attenuation if you combine them all together. What guidelines recommend nowadays? In European Society of Cardiology, they stick to all the treatment, diuretics, class 1, and management of comorbidities. The European Society of Cardiology guidelines just released before the, maybe hours between release of the EMBERIOR PRESERVE and the release of these guidelines. So they missed the EMBERIOR PRESERVE. That's why you don't see any SGLT2 inhibitors here. In ACC, they got their guidelines after EMBERIOR PRESERVE and before DELIVER. So they bought again diuretics as a class 1 and SGLT2 inhibitors as a class 2A ARNI, ARBAS Class 2B, MRA Class 2B, and management of comorbidities. Okay, we have this very interesting algorithm this is very recent 2023 ACC expert consensus pathway. And if the first observation here in this algorithm, no beta blockers. So no role of beta blockers in HFpEF treatment, except if you have indication for beta blocker, like coronary artery disease or atrial fibrillation, but it's not among the treatment or algorithm here of HFpEF. We have here the SGLT2 inhibitors, and it is very interesting here. They put the yellow, and then the outlines are like green. So they are saying that next guidelines will be green. For patients with congestion and symptomatic, of course, low diuretics. For patients who are women or ejection fraction with ejection fraction like in the below 60, and those with a fluid retention, MRA if tolerated, and ARNI for women, all ejection fraction, and men with ejection fraction below normal. And if the patient is eligible, but we have he cannot take the ARNI because of cost or intolerance, then we give ARB. So if you look to the treatment of heart failure across all spectrum of ejection fraction, we have the beta blocker for HFrEF. We have ARB for HFrEF. We have extended use of ARNI up to we can say below normal. MRA also if tolerated, and we have the SGLT2 across all ejection fraction. Just in summary, HFpEF has various etiological, pathophysiological, diagnostic, and therapeutic heterogeneity. Therapies that have been successful in heart failure with ejection fraction below 40 also appear to have some benefit in patients with heart failure with more than 40%, but this benefit declines as ejection fraction goes into and above the normal range. And we have SGLT2 beneficial across range of ejection fraction, age, glycemia, kidney function, background therapies, or a clinical setting. Before closing, I must say that we have a residual risk, and that's why we have more work to do. Thank you for your attention.
Thanks a lot, Dr. Badri. What a talk, really very comprehensive, covers it all. It starts from where Dr. Matlooba left and with the Blitz-Ford lab, and you just really, I think, very interesting way of presenting it, and I personally learned a lot. And I'm sure there'll be a lot of questions later on. So moving on, this will be my last talk. This is important to be really sort of talking about ARNI and HFpEF. I've been asked to remind you that for those who require CME certificate, they need to fill the survey that comes at the end of the whole session. So you fill that in, and you receive the certificate. Please continue. We had a few questions already, so we need 2 more questions, which we'll go through at the end. So this is my turn now. So let me just put my presentation up. Let's make this big. Okay, so great to be here. For those who were not here at the beginning, I'm Dr. Harari, I'm a cardiologist at Tawam. So what I'll be talking about now, with the chance being given, is the practical consideration in the management of HFpEF, basically the role of ARNI in these patients. So when I go up, again, as Dr. Salah had a bit of overlap with Dr. Matlooba, I'll have a bit of overlap with what he said. He said a lot of what I'm going to say, to be honest. And just take from there. So I think repetition is not bad, really. It's for us to emphasize a few points. So talk about pitfalls of ejection fraction. Just go what's ejection fraction, why we divide it this way. And then again, the clinical characteristics of HFpEF patients, again, it's been mentioned by Dr. Motloub and Dr. Badri. And the previous thoracic blockade trial therapy for HFpEF. And then we'll go to the main block with the role of ARNI for HFpEF, the Paragon trial. So I will not talk about the Paramount or Paragon line. They are smaller trials with beneficial, predominantly in reducing N2.B safety, and both in the chronic and the acute sessions. But the large trials, the Paragons, we'll go through it in some analysis of it, like what if they've expanded their primary endpoint to include urgent heart failure visits, and the subgroup that Dr. Salah mentioned, those with ejection fraction less than 57%, and the women. And again, if we initiated the early in the post-discharge patients, would that be more even beneficial than the chronic one? As analysis from the Paragon itself, and then we will look at the data of use of ARNI across all ejection fractions, because they have two major trials, for HFrEF, HFpEF, and if you add them together, it's a huge number of patients. And if we put the data all together, does it change a little bit of the message or the outcome? And then ARNI versus placebo. Now, probably ARNI were the only trials in heart failure that studied the ARNI against active comparator. All the other trials were against placebo, whether it's the TOPCAT, whether the CHARM Reserve or the SGLT2 inhibitors, they were all against placebo. But these trials, the Novartis people were very brave to test their drugs against an active comparator, which is known to be beneficial. So what if, theoretically, or by analyzing data, look at the use of ARNI against placebo across all ejection fraction? And the guidelines Dr. Salah has mentioned, and I probably won't even mention them, and also the latest, just last month, the ACS Expert Consensus Decision Pathway in the management fund. Just Dr. Salah already mentioned, I'll probably just go over it in a few words. So, this ejection fraction business, really, I mean, you probably all know that actually, how did it come about? We were not born at like separate people with different ejection fraction, or suddenly we become 40% and suddenly we become 50%. This is a continuous spectrum. And the trialists at the beginning, they wanted to test their drugs or devices on those who had higher stress. So if you want to test a drug to be beneficial, don't test on low risk patient, because you will waste a lot of things. You will do a lot of big trial. You need a huge number to reach the PowerPoint, and you probably risk of failing. But if you take the highest risk and you test your drug, then if your drug or device is beneficial, will show up. So they use the cutoff figure of less than 35 or 40%, knowing these are the bad ventricle, these are the bad high risk, those are the benefit. This is where this is started. And initially, anyone above 40% were called HFpEF. So HFrEF was less than 35, 40, but HFpEF, anything above 40%. And then this small group of 40 to 50 or 41 to 14, whatever you want to call it, created. Initially, they called it mid-range, and initially they said this is for research purposes. We're not going to talk even about the management, but just for research purposes. And then it became labeled as mildly reduced, and we know the guidelines therapy approach. And anything above 50% become the HFpEF. But this is really ignore the continuous nature of ejection fraction. It's not like a 40 and then 50 and then 60, whatever. It's a continuous nature. And there's uncertainty in measurement. And you do one echo one day and the other person look at it and will give you a different figures. And you do it by the MAGA, different from the echo, whatever. And would you really treat somebody with ejection fraction, say even 37%, completely different from one of 42%? You wouldn't, would you? So it is just bear that in mind, really. Dr. Salah al-Badi has really elegantly told you that the HFpEF proportion or prevalence is gone up. So the heart failure generally is gone up. We are diagnosing more heart failure, getting older, whatever, but the number of heart failure patients is going up throughout the world. But the proportion of patients with HFpEF actually become now more 50%, while the proportion of HFrEF actually 35%. So we are diagnosing more and more HFrEF because we are getting better at diagnosing it, despite the challenges we have. Symptom-wise and signs-wise, they are not different. So if somebody, you look at somebody tell you the story and breathless edema or whatever, you examine them, you're most likely find quite very similar signs and symptoms. So you cannot tell from that. But the HFpEF patient, as you've been again mentioned by Dr. Salah, they have a much higher comorbidity. They tend to have more hypertension, more CKD disease, more AF, more anemia, more stroke, more comorbidities. So they tend to have more comorbidity. They tend to have actually worse lifestyle. So the quality of life tends to be poorer. They tend to, difficult to work, difficult to look after themselves. They cannot work, stuff like that. You cannot sometimes work. And you probably, if I tell you, describe a HFpEF patient in your clinic, you can imagine the last patient you see. It's usually somebody, probably even in a wheelchair, probably an elderly, probably obese, probably hypertensive, CKD, atrial fibrillation, very common, diabetic, very common. So these are the phenotype patients. Dr. Salah told you these are patients. This is a syndrome that probably starts outside the heart and go affect the heart rather than the other way around in HFrEF patients. They tend to have a very similar risk of hospitalization compared to HFrEF, very similar mortality. So HFpEF is not a benign condition. The cause of death differs. Patients with HFrEF tend to die mostly because of progression of their heart failure or sudden death in more than 50% of patients. While they have HFpEF, they tend to die from other cardiovascular causes or non-cardiovascular completely in more than 56%. And the risk of their death because of sudden death or progressive heart failure is actually less, or just 30-35%. And the HFrEF and MIRF are in the middle. So bear that in mind. In the past, we tried so many drugs, but they really failed to show us convincing mortality and morbidity benefit. The ACE inhibitors, as much as they were good in HFrEF, they were not really good in HFpEF. Again, Dr. Badi did mention to you that the CHARM Preserve trial, which is really a large trial, tested candesartan versus placebo in a big number of patients with heart failure with ejection fraction more than 40%. So, and it failed to reach its primary endpoint of the composite of heart failure, hospitalization, cardiovascular death, but it did reduce heart failure hospitalization and remains and still as class 2B. Dr. Al-Badri mentioned arrogantly about the TOPCAT trial, which was a funny trial in a sense of the outcome or whatever. And the headline says that again the study was negative because it did not meet the primary endpoint of reduction of heart failure, hospitalization, cardiovascular death, or resuscitation from cardiac arrest. It did reduce heart failure hospitalization. But the study, as Dr. Radi mentioned to you, it was carried predominantly in two continents: the American, Canada, America, Brazil, and the Russia and the Georgia. And it's very strange. And actually, if you look at the criteria for diagnosis, either a history of heart failure or raised BNP, doesn't have to be both. And when they looked at the American and the patient in red, and those on the active treatment are the dotted line in the red, and the solid are on the placebo. They found the American, actually they are on the spironolactone, they're more likely to have lower blood pressure, more likely to have a higher potassium, more likely to have a higher creatinine, which really what you expect somebody when you put a lot of patient on spironolactone. But the Russian and Georgian, that did not happen. So were they taking the drugs? I don't know. And again, when you look at the benefit, the American did derive significant benefit from being on the spironolactone in the red dotted line compared to the solid, while the Georgian, the Russian, the blue, solid and dotted, they're overlapping. So they did not have benefit from being on spironolactone as far as reduction in primary outcome or cardiovascular death or heart failure hospitalization. So was the study really negative? We don't. As you can make of it as much as you can, or as you want. So moving on to the ARNI, Again, just briefly, only so you know, it's two drugs. Valsartan, Sanar, that blocks your angiotensin II receptor. So it stops the bad effect of the angiotensin II, the vasoconstriction, the elevated blood pressure, the increased aldosterone, etc., etc. And the other component is sacubitril, which really inhibit the neprilysin. Neprilysin is your bad guy. Neprilysin damage your BMB, and you need the BMB because it vasodilator, inhibits your bradykinin, inhibits your angiotensin II. So by blocking the neprilysin, you have more BMB, you have good effects. So you block the angiotensin II, and you have more BMB. So it's a good combination. And I'm not going to mention the two smaller trials, the Paramount or Paraglide, but I'll really focus on the Paragon trial. It's a huge trial. It's nearly 5,000 patients of HFpEF patient with ejection fraction equal to more than 45%. Again, randomized to what? Sacubitril valsartan versus an active comparator, valsartan, which you know from the charm, actually they are not bad drugs. So against active comparator. The drug actually, those with sacubitril valsartan did derive benefit from the primary endpoint of total heart failure hospitalization or cardiovascular death with a reduction of 13%, but it just missed the statistical significance. And we'll come to that later on in more analysis. So the primary endpoint was not met, just margin. Now, however, we told you that the HFpEF patient really disease of comorbidity. Actually, the death from cardiovascular death actually is much less than HFpEF. Actually, they have poor quality of life. This drug, sacubitril valsartan, really improve their quality of life. They improve their NIHA class, improve your KCCQ class. They actually protect their kidney compared to valsartan. So it does a lot of good things, even the totality of the group. And this is the kidney. Now, what they did not do in the Paragon, they actually registered. They have the data of all what they call the urgent heart failure visits. So patients become worsening heart failure, edema, they go to ER, and they get IV furosemide, and they don't get admitted. They go home. So they have a lot of patients who had this, and those people, as those would get readmitted, readmission is mark of worsening. So those who get readmitted, the brown thing, they did worse on the study follow-up. And also those who tend to attend for urgent heart failure visit, they tend to do worse. So if they include those urgent heart failure visit and look at them as in the way of whether they benefit from sacubitril valsartan, if they add them to the heart failure hospitalization and cardiovascular death, as in the graph on the right side, the study would have been statistically significant. So, considering or adding urgent heart failure visit reinforced the treatment efficacy of sacubitril valsartan compared to valsartan in the HFpEF patient generally. And again, as Dr. Salah mentioned, if we look to pre-specified subgroups, particularly this group with ejection fraction equal to then 57%, which is still high, but is just subnormal. These groups actually get 22% reduction of primary endpoint if they are on sacubitril valsartan versus valsartan. And the benefit in this group is quite big. Actually, it's quite comparable to the benefit we will get from sacubitril valsartan in the Paradigm trial. In the Paradigm trial, if you treat 1,000 patients with sacubitril valsartan, you prevent 122 primary event and 76 hospitalization in 3 years. In the totality of the Paragon, the number is much less of the number you prevent by being sacubitril valsartan. But if you look, if you look at that group with ejection fraction less than equal to less than 57%, the number of events prevented is quite big. Being on sacubitril valsartan versus valsartan is almost comparable to the Paradigm trial. So those groups do benefit, and the other group, actually the females, we actually were more about 52% of the study group were females, and all females across all ejection fraction had statistically significant benefit from beyond sacubitril valsartan as far as the primary endpoint reduction is concerned. And if you are a female, as there is a solid line on sacubitril valsartan, you do much better than if you are a male, if you are a female on valsartan or if you are a male, both in the reduction in the primary composite endpoint and the total heart failure hospitalization. So women benefit regardless of ejection fraction. All group benefit up to ejection fraction 57%. If you really consider the heart failure hospitalization is important and you want to prevent, attendance to heart failure emergency room for diuretic important, then you will benefit from being secure regardless of ejection fraction. Now, this has also been alluded to by Dr. Salah, and I'll just go over it. Now, we know even from the heart failure with reduced ejection fraction and heart failure generally, that people get admitted, they have a worse prognosis. And usually the highest risk of death or readmission is usually within the first few months or first month. So the period during hospitalization and early afterward is worse. Has that been shown in the Paragon trial itself? Yes, it was. So the Paragon trial patients who were recruited after being hospitalized, within 30 days being hospitalized, do much worse compared to, for example, if you go to the bottom yellow line, patient who've been recruited but no heart failure before. And the closer the recruitment towards admission, like 31 to 39 or 30, is worse than if you're recruited after 180 days. And obviously you do better if you never had been admitted with heart failure. So basically, having heart failure admission is worse in your prognosis, and particularly in the early period. Okay, did given sacubitril valsartan in the Paragon trial to those who have been recruited earlier benefit them? Yes, it did. So in this paragraph, those who were actually recruited within 30 days, you have the most significant benefit from being sacubitril valsartan compared to those who were being recruited within 30 to 90 days compared to those who were recruited later. So the earlier they were started sacubitril valsartan, the better they did. And as I said, if we look at the use of sacubitril valsartan across all ejection fraction, low and high, and how we do that by combining the data from the Paradigm trial. Again, it's sacubitril valsartan versus an active comparator, which is the enalapril, and the Paragon, which is sacubitril valsartan versus valsartan. The work was done by Joe McMurray and his group and published in Circulation. And basically, when they analyzed the data as a one group, sacubitril valsartan versus an active comparator, they found actually there was significant reduction in all cardiovascular event or outcome. And if you look to the graph on the right side, the bars in the blue, when they combine the data, so whether it is cardiovascular death, heart failure hospitalization, or heart failure hospitalization, or cardiovascular death alone, or all death, they're all better off being on sacubitril valsartan across all ejection fraction. And this is up to ejection fraction of 60% in this analysis. And basically the effect, as Dr. Salah showed you with the MRAs, and to be honest, even with the CO2 inhibitors and with the R, the RNA benefit tends to attenuate towards the high ejection fraction, particularly in male and the blue. So the benefit probably won't be there around 57% or something like that. While in female, the benefit tend to extend to a higher ejection fraction, the red one. So the female to the benefit even at the high ejection fraction from being on RNA. And obviously the benefit is highest in the lower ejection fraction, but it did continue up to 57% in males and even higher in females. Again, so the question then, I said the RNA was the only drug in the heart failure in the large trial that studied always against active comparator. So what if it was studied against a placebo? Obviously, that study was not done, but again, John McMurray and his group, what they did, they put the data of the Paradigm and Paragon together. So this is your RNA group, obviously versus active, and then compare them or study them against the CHARM, an alternative, which is candesartan versus placebo in HFrEF patient, and the CHARM Preserve which can disartan against placebo in HFpEF. So arm 1, arm 2, arm 3. So this is a lot of work they did, but basically their conclusion that from the HFrEF point of view, if the paradigm was done against the placebo, security for against placebo, the benefit will be actually 48% reduction, staggering number reduction of the primary endpoint. And in the Paragon, if it was studied against placebo, the reduction in the primary endpoint will be 29%. And this benefit would have seen across all outcomes and to even higher ejection fraction. You see here, all the outcomes would be better reduced if the security for time was studied against placebo across all ejection fraction, even to a higher ejection fraction. And as you know, the FDA in 2021 did expand the indication of sacubitril/valsartan, making it a heart failure drug medication without specifying ejection fraction. It did not say this is for HFrEF only. It just did not specific, but did highlight that the benefit will be to those with subnormal ejection fraction. And the guidelines that Dr. Salah mentioned, really 2021, the European, emphasized the importance for screening, diagnosing, and treating the underlying comorbidities, whether it's AF or ischemic heart disease or hypertension, and also the use of diuretics. The American from last year, again, put the SGLT2 inhibitor as class 2A, rightly so, and now probably should be class 1, because now we have 2 trials, the DELIVER and the MPEP Reserve, and give the ARNI and the MRA and the ARB as class 2B. And in this last month paper from the American College of Cardiology Expert Consistent Decision Pathway that Dr. Badri highlighted went through, basically tells you SGLT2 inhibitor should be now green, should be class 1. So this is for all HFpEF. And those who are congested, then diuretics or and MRA. But then it advised to use ARNI for all women and all male with ejection fraction subnormal less than 55.6%. The ARB should be used only if ARNI cannot be used for cost or intolerance. So in summary, ladies and gentlemen, Paragon was the largest and the only active control. So, it's against active comparator trial in HFpEF. Despite missing narrowly the primary endpoint in the whole study, there was clear modest benefit, particularly if you consider the urgent heart failure visit that was included. And the benefit was seen regardless of ejection fraction in women and in all patients with ejection fraction equal to less than 57%. The benefit was seen to be maximum early after discharge, and we know from Paraglide even during hospitalization. So the earlier you start this, the better, and they get the maximum benefit. And this was the first drug before the SGLT2 inhibitor came on to be approved by the FDA across the whole range of subnormal ejection fraction. And the latest SC expert consistent decision pathway recommends the use of ARNI in all women and men with subnormal ejection fraction. And that's it.
Thank you, Dr. Mohammed. Elegant talk. Thank you.
Thank you. Now, I think we will open the floor for questions. I think there are a few questions on the diagnosis, Dr. Matluba. If you are with us, if you want to go through them, I can read some of them for you.
Yeah.
So, for example, it says, why does atrial fibrillation have the highest points in the diagnostic HFpEF algorithm?
Yeah, so atrial fibrillation and HFpEF usually they overlap in certain things in the symptoms. HFpEF and atrial fibrillation can present with the similar symptoms. That's number one. For example, shortness of breath, fatigue, exercise intolerance, and also they share kind of similar underlying pathophysiology. as well as there is a shared risk factors for both atrial fibrillation and HFpEF. And the common risk factors that include, as we know, elderly age and patient with hypertension, diabetes, obesity. So these are the underlying risk factors would be shared by HFpEF and atrial fibrillation. So I guess these could be the most important reasons why atrial fibrillation have highest point in diagnosis of HFpEF.
Yeah. Yeah, to be honest, I was also not sure why it was 3, but I know probably the reason, just because AF it is associated with HFpEF. So having F is making you more likely to have HFpEF than HFpEF or not having HFpEF.
Probably Dr. Muhammad, if you allow me.
Please, yeah.
The HF patient will have like a enlarged left atrium in most of the cases, and a irritable left atrium, and then probably this is an association. And as I mentioned, the epidemiological study saying that if you are a woman and atrial fibrillation, then you're more likely to have HFpEF. And that's why they put them, they gave the maximum just to include more cases, I guess.
Yeah, so it's shared, the underlying pathophysiology, that's also one of the factors which play a role in highest point in diagnosis of HFpEF for patients with atrial fibrillation. Yeah.
Yes, true.
Yeah, and I think also Matluba, there was a question, it said, if HFpEF is not a diastolic issue, so what is it exactly?
So I think we mentioned this in my talk, and Dr. Salah also mentioned it. So we know that diastolic dysfunction, usually it refers to general abnormalities in heart failure during diastole, and HFpEF is specifically, it referred to heart failure, and it is primarily also caused with the diastolic dysfunction. I think there is another question as well, which is related to this. I think the question, if you just read the question, Dr. Hariri, the second one, they were, where it's gone. So there were 2 different questions which is correlated together. So they said, would this statement be true? A patient with diastolic heart failure always has HFpEF, but not vice versa. So I think these 2 questions is somehow correlated together because diastolic heart failure also, it can be a component of HFpEF, but it's not synonymous with HFpEF. So it can, it can be that cases of HFpEF not solely due to diastolic dysfunction, but other factors can contribute to the condition. So again, there is a kind of shared underlying pathophysiology, and also a healthy patient can has diastolic dysfunction, and also the comorbidities that could be one of the criteria for it.
Yeah, I think there's also, to be honest, some people argue that even in HFrEF, you may get accidentally, you find somebody had ejection fraction of say 40%, but you do the BNB normally, you question him, you do everything, it's all negative. So these still don't have heart failure, even though they have underlying structural abnormality. So, this is underlying diastolic function in itself. It's not a diagnostic, and you elegantly mentioned in your talk that you can find it in normal, healthy people. So
yes, I agree, Dr. Muhammad. The HFrEF, as we know, will have also diastolic dysfunction. So and the HFpEF, we can have a systolic dysfunction in form of global longitudinal strain impairment. So it is difficult to distinguish or give the diastolic, function as a tool to differentiate these 2. And as we mentioned, Dr. Matluba, we can see it in healthy persons. So it's useful, but it should not be synonymous. This is the term used by Dr. Matluba. I agree 100% with HFpEF. We can have the diastolic dysfunction both in HFrEF and HFpEF, and we can have the systolic dysfunction even in HFpEF. This is the just summary. Yeah.
Dr. Matluba, do you use these scores in your routine clinical practice? Because I found particularly the European, although it's really comprehensive, but actually it's not that easy to apply when you are in a clinic seeing a patient.
But yeah, actually, it's very challenging. I mean, as you know that in previous era we were just practicing HFrEF, and HFpEF is just introduced in our practice. And the cases of HFpEF that we've seen, they are usually HFrEF who are improved with the medication or converted into the HFpEF. So yeah, sometimes it is useful, but most of the time, to be honest, no. I mean, I'm not into the scoring algorithm for the diagnosis, but it would be very interesting actually to use it. So I'm planning to get used to it. It's a bit challenging in the practice.
I think Dr. Al-Badri mentioned his talk. Thing. I mean, there are straightforward cases on there. There are straightforward cases you can diagnose, no problem. I think probably when you get the one that you're not sure, that we start thinking about scratching your head. What's their A prime? What's their, and then you may think of the score and you try to apply it. Would that be applicable to them? And that helps you to diagnose. Particularly as you with the normal or low BNP. I mean, I'm sure you have. I have patient failure. Despite normal BNP or very low normal BNP, actually they did benefit. And actually, one of the way actually of diagnosing is trying. So if you're really struggling, you're not sure, you don't have to facility to do invasive. You just put them on SCO2 inhibitor, a bit of diuretic. I know it is always subjective, but if you find actually next week or next work time, if they feel great, then it helps a bit. So as you mentioned, the score. Because actually, when you said that when they've been validated, actually even with the score, you still miss HFpEF. So you should not use it and solely to it. And as you mentioned, there are cases you can apply the score, and it's the heart failure, but actually they are not heart failure. So being above 60 and having an atrial fibrillation does not necessarily mean that you have heart failure.
Yeah,
it's all interesting. I think there's a question, Dr. Salah, they said, why to avoid thiazolidinone and glivintins in diabetic with HFpEF? I think you mentioned it.
This is an excellent question. And the simple answer that if you look to the guidelines in 2019, the diabetes guideline of cardiology, they are class 3, and it should not be used. And this will take us back to 2008. If you remember, Dr. Mohammed Afandi, of course you remember, when it was removed from the market, the resiglitazone. And, the resiglitazone is the cause of bringing SGLT2 inhibitor and GLP-1 agonist to the market. The FDA said, if you are bringing any new anti-diabetic, we need to prove that it is safe. So then they did safety trials, the EMPA-REG, DECLARE and others. And the surprise was that they are not only safe, they improve cardiovascular outcomes. But, the resiglitazone was removed and it's not anymore. About gliptin, I didn't say they should not be used because we can use them except saxagliptin. It was studied in SAVOR trial, and it was associated with around 27% increased risk of hospitalization. So gliptin are neutral. They are not beneficial and they are not harmful, like CETA and others, We can use them safely. So not all gliptin, only saxagliptin should be avoided.
We still see patients with heart failure on biglitazone. I think
they do. Yeah.
This is a question to you, Dr. Salah. He said this from Zuhair Samari said the idea of HFpEF as part of systemic inflammation is new to me, and it's very interesting. It seems we are dealing with different disease. You're just basically emphasizing what you said. I think it's really interesting. It's important to that there are really different diseases. And I don't know whether you have comment on this, Salah.
Yeah, I agree. This is a new concept now, and now the all new trials are getting into this subject. The obesity is an inflammatory disease as well, and we have now new medications coming to treat the inflammation of the obesity as part to improve the cardiovascular outcomes. So if you deal with it as inflammatory disease, then we have to treat the whole body, skeletal muscle, lung, these will be all associated with, like if you treat, as I mentioned, SLE, you give something more broad spectrum, immunosuppression, or to treat everything in one line.
Yeah. Another question, one who said, why was Valsartan chosen to be studied in combination with sacubitril as opposed to ACE? Okay, I think because sacubitril actually by inhibiting your neprilysin, you increase your bradykinin, and angiotensin II, and that's where you block them. As far as the use, why the use, the question that always comes: why the Novartis people decided to use active comparator, which you can say they showed themselves in the book. But the problem with this question being raised, I think my understanding that most HFpEF patients, there are a lot of comorbidities, and most of them are hypertensive, and they would have needed to be on something. And if you do just placebo, you find someone ACE, someone ARB, someone whatever. So they decided to just compare them with an active comparator, and they choose for some time for that.
Yeah.
A question maybe you, Dr. Salah, said, how to treat HFmrEF, like HFrEF or HFpEF?
This is a tough question, apparently. I think as Dr. Muhammad mentioned, we tend to treat with the same things. I mean, the treatment of HFrEF will be almost the same as extended to everything. Probably I will treat with everything. The beta blocker issue we have just mentioned. If you have,
yes,
especially preserved ejection fraction, I know a lot of patients are on beta blockers because of many other reasons, like coronary disease, or ischemia, atrial fibrillation. But if you don't have a clear indication and your patient is not reduced ejection fraction, probably if you stop the beta, and this was studied actually, we have new articles and studies saying if you remove the beta blocker, then the exercise, tolerance will improve for your patient. So this is maybe a request to review patients in your clinic, and you just kindly see if the beta blocker is really indicated and the patient has a heart failure with preserved ejection. Of course, if you have indication, you need to continue. Otherwise, I think beta blocker is not among the treatment of heart failure with preserved ejection fraction.
Mm-hmm. Just guilty because the way I do it really now, actually, it's completely the reverse. So in HFrEF patient, I want the heart rate to be low. I want to be below 70, and I do as much as I can. Brandin, Jux, and whatever beta blockers. But while in HFpEF, I do the opposite. If I find my patient actually the heart rate like in the 60s or 50s, I know it's not good. I ease on if they are on beta blocker for a good reason, and if not, I stop it altogether. So it's completely the opposite, even though.
Yeah.
So it's really interesting.
I agree. Again, Dr. Muhammad, some phenotypes of heart failure with preserved ejection fraction will have a small ventricle, small stroke volume. If you lower the cardiac output, stroke volume multiplied by heart rate. And if you just decrease, decrease the heart rate, then the cardiac output will be less. We have to be very careful on this. This is also manifested in patients with very high ejection fraction, like in amyloidosis. The beta blocker should be avoided because they have the same, principles.
Yeah.
This question, both you read them. Any comment on the use of finerenone? Where do you see finerenone in HFpEF? I know the study hasn't been
Yeah, we are waiting. I guess fine arrest, fine arts trial. I think they are still in. But I think because spironolactone was, for me, successful.
Yeah.
I guess this is the non-steroidal mineralocorticoid, which is the finerenone. I think it's promising. I guess it will be one of the addition.
Yeah.
True. Yeah. The same idea actually. Yeah.
So, I mean, talk about that top cat. I mean, knowing what we know, do you use spironolactone routinely for your HFpEF? So,
Well, well, actually, yes, I believe in it, and I do use it. I do use the spironolactone in HFpEF. Yeah.
Dr. Muhammad, 40% of patients of deliver were in aldosterone. So we use it. I mean, as general, internationally, globally, we are using aldactone as treatment of HFpEF. The only thing that tolerance. And one practical point, if you're using spironolactone or MRA in general, if you start ARNI and SGLT2 before them, then the patient will tolerate it because the hyperkalemia will be less. This is studied in Paradigm and TopCat as well. So, I mean, in Paradigm and DABA-HF. So, if you use SGLT2 inhibitors and ARNI before aldactone, before adding aldactone, then the patient probably he will tolerate the medication very well.
just like and is it DABA or IMBA, or is it the class effect?
What they said in the meta-analysis, we just mentioned they are same, the class effect. This is what they conclude. Just to be, the meta-analysis, they are same as a class effect. Yeah. Even the issue of attenuation was not there in the meta-analysis, the pooled analysis.
Matluba, same comment or any comment?
It's the same comment, and again, it depends. Actually, in my practice, like whichever MOH or Ministry of Health make available, so I'll go for it. So either DAP or IMPA, but it's the same comment of Dr. Salah. Yeah, currently we are using DAPA.
Yeah, some will say, as HFrEF, the cardiovascular death was, clear, and DABA-HF was not there, and very reduced. Some will use that as an excuse to use dapagliflozin.
Yeah.
So this is, variable according to the practice and preference,
Yeah, I agree. I think it's classic. I think it's really been a great session. I learned a lot, and I enjoy the company. So I'm just going to mention a couple of summary from what I heard. And please remind the audience to fill the survey before they sign out if they want to get a certificate. So basically, the diagnosis of heart HFpEF can be straightforward, but can be difficult, can be challenging. Use the universal definition of heart failure as a baseline, your clinical assessment, the congestion, the BNP. And if you got all that and this underlying structure of the margin of the heart that we are not going to detail, if you are, and in most cases you will get your diagnosis, but do not dismiss HFpEF in obese women who short breath just because their BNP is low. You may have to use a score for this patient to help you to diagnose. Exclude the mimics, Dr. Matluba highlight that clearly. So your echo will clear a lot for us. Like the heart disease, the HOCMs, if you suspect amyloidosis, think about it and exclude it. Those were clearly liver failure, nephrotic syndrome, so just don't put it down to all heart failure. HFpEF is a systemic syndrome. We've heard it now a few times, an interesting concept. And you have to investigate and treat the underlying pathology, whatever that is, hypertension, ischemic heart disease, AF, you have to treat that. Now we have really a treatment that actually showed a reduction in outcome, the SGLT2 inhibitors, the MRAs, the ARNIs, and then they are not the beta blocker. It's been a great session, and I really thank you and look forward to meeting you physically or having another session together. Thank you.
Thank you, Dr. Muhammad. Thank you. Thank you so much.
Thank you very much, Dr. Mohammed. Thank you,
you, Dr.
organizing
Mahmoud.
committee. Thank you. Thank you, Dr. Salah.
Thank you, Khalid.